Hello, and welcome to this presentation, Medical Billing in the Healthy Airway Practice. My name is Dr. Chris Ferrugia, and in the time we have together, I'm going to be exploring medical billing with you and take you along a ride with my professional journey. Before we begin, I want to give you a little bit of a disclaimer, and this is really just so you'll know a little bit more about me and where I'm coming from. But first of all, you need to understand that English is not my first language. I grew up in the South, and my native language is Southern. And no matter how hard I try, I will slip into Southern dialect, probably throw in a little bit of slang, but that is just who I am. It's unavoidable, and I will say y'all, and that's going to be a problem for me because I don't want to do that. But again, that's just who I am. The other thing is that I have a dry sense of humor. It is unavoidable. It is not controllable by any medication. And no matter how hard I try to keep it out of my presentation, I just can't. So with those two warnings and disclaimers, let's go ahead and go forward. Now, all of us began a professional journey when we got accepted to dental school. And your journey is going to take you in different directions. Mine led me a certain path, yours has led you to a certain path, but here we are together today. And what I want to explore with you is I want you to think about, as I go through my presentation, where exactly you are in your professional journey and where you aspire to go, and the level of healthcare that you aspire to provide to your patients, because all of these things are intermingled. Practice of dentistry, practice of medicine, medical billing, airway, all of these things are converging. But what I'm going to hope to do to accomplish, I'm going to tell you some things that you need to know about medical billing, that you actually have to know in order to have a chance at succeeding with this. I'm going to tell you the things that I think that you want to know. And then in our question and answer session, we'll be able to answer anything that we haven't covered to that point. But the biggest thing that you need to start to understand about medical billing is not about codes. There's a great misconception that medical billing is nothing more than if I have the right codes, then medical insurance will pay me. Nothing could be further from the truth. And it's a perception problem. Succeeding with medical billing in a dental practice is a perception problem. So as we go through this presentation, my goal more than anything else is to change your perception, to cause you to think, to cause you to see things differently, just as you're doing as you're listening to other information about airway today. Perception is everything. This is Mount Rushmore. But if we look at the exact same thing from a different perspective, we'll see something else. That's Mount Rushmore from the Canadian side. We're looking at the same thing, but seeing entirely different things. So again, perception is the key. But any journey starts at the beginning, and this journey is going to start at the very beginning. Let's start at the very basic fact. Are dentists allowed to bill medical insurance? Yes or no? How is that possible? We're dentists, that's medical insurance. How is that possible? Well, if you consider what the ADA defines the scope of our practice to be, you'll notice that it says that the practice of dentistry is the evaluation, diagnosis, prevention, and treatment, blah, 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 of the oral cavity, maxillofacial area, and or the adjacent and associate structures. You'll see that the word tooth does not even appear in the definition of the scope of our practice. And that definition is embedded in the state statutes of all of the states that we practice in. But we're not about the teeth. As a matter of fact, tooth is not even in the definition of the scope of our practice. So perhaps before we go any further, let me go ahead and introduce myself to you formally. Not because I'm great and wonderful, you'll make up your mind about that before the end of this presentation, but I want you to understand where I'm coming from. And again, this is my journey, and I'm going to explain it to you and how I got to where I am today so that you can consider where you want to go from this point forward in your journey. So my name is Chris Ferrugia. I am a practicing dentist. I have a DDS degree from Emory University. Yes, I know that that's closed, and DDS does not stand for Discontinued Dental School. But we all were accepted to a dental school, and that marks the beginning of our professional journey. And we all remember in dental school the emotions that we experienced in our senior year as we were approaching graduation, where we were going from feeling like we knew everything to feeling like we knew absolutely nothing as soon as we were licensed and began clinical practice. But I started my journey at Emory, and today I practice TMD and dental sleep medicine in Destin, Florida. And that's because that's what I love to do. My journey began with graduation in dental school. I entered private practice, and like everyone, I was indebted with student loans and car payments. I bought a practice. There was debt. I just wanted to make a living. I needed to learn more and continue my journey. But my journey first significant turn occurred by going to the L.D. Pankey Institute. I wanted to become the best restorative dentist that I could be. And that was a great place to learn about restoring teeth. And again, I thought that dentistry was nothing more than teeth. But at the Pankey Institute and at subsequent meetings, I've actually run into a dentist named Dr. Pete Dawson. And Dr. Pete Dawson explained to the group, you will have to decide if you want to be tooth mechanics or physicians of the mouth. Now that's actually a very profound statement, but at the time, that seed was sown on infertile ground. Again, I was heavily in debt, started a family, and just trying to get through life and make a living. And I thought that dentistry was nothing more than teeth. As a matter of fact, isn't that what we were taught in dental school, is teeth? That's all we were taught, and very little else. So at that time, my journey was taking me toward trying to become the best restorative dentist that I could. And I wanted to control the process of being the best restorative dentist that I could. In dental school at Emory, they told us that when you graduate, you need to go into private practice and find the best laboratory technician that you can find and beg him or her to do your work, because they are going to make you look really good. Well, in the area I was practicing, there weren't really any great laboratory technicians. And in order to control the process, that led me in my professional journey to CAD/CAM. And in 2000, I was actually a very early adopter of that technology because I simply wanted to produce the best dental restorations that I could and control the process entirely. And I went even further. I dived even deeper into that. I purchased the companion in-lab system that goes with that. And I actually opened a dental lab to become a laboratory for other dentists so that they could do dentistry of equal quality that I could. But a large shift in my thinking occurred in 2011 when I added CT to my practice. Now, I was focused on being a restorative dentist like a lot of us are, and I was all about the teeth, but at this point, after mastering restorative dentistry, I wanted to expand my knowledge, to increase the level of care that I offered to my patients. And it was in 2011 that I decided to add CT to my practice. And that had a huge impact in my practice. Now keep in mind, I don't do surgery. I don't do implants. I just choose to do restorative dentistry of that type at that time. And CT is a no-brainer when you do surgery, but for a non-surgical dentist, I bought CT simply to become a better diagnostician. But it's the purchase of CT in my practice that led me to medical billing. because it became very apparent that CT is a very expensive piece of medical equipment. It performs an expensive medical test and is paid by medical insurance. So I wondered, why wouldn't medical insurance cover this for me? And that began my journey into learning how to successfully be paid by medical insurance for CT. I just simply wanted to pay for the machine, nothing more than that. But along the way, I learned all of the other things that are payable by medical insurance, including things that we're going to talk in depth about. Now, I have written 5 books on the subject, and I've been paid hundreds of thousands of dollars in medical benefits. So I do have some level of expertise in this subject. But concurrent with the addition of CT in 2013, in 2012, I actually started treating obstructive sleep apnea patients in my practice as well. So between CT and treating sleep apnea, those two things had a profound change on my practice. And I didn't realize this before I began the process, but it actually caused a shift in my practice. And my practice ceased to be a dental practice and became a medical style practice that also treats teeth. That is huge. That is a different perspective and a different mindset. And when I began treating sleep apnea patients, I heard the phrase or the saying that sleep apnea is a medical problem with a dental solution. Now, I don't know who to give credit to that quote to, but it's very, very common and passed around at meetings and congregations of dentists as they discuss this subject. But I will tell you that I absolutely hate that saying now, knowing what I know now. And later we're going to come back to this and I'll explain why, but you should begin to see why that is just not an accurate thing to say at all. And another thing about medical insurance, when you choose to do this in your practice, you're going to have to make a decision. And I know you're probably waiting for the first profound thing for me to say so you can write something down, and here it is. In your practice, if you're going to treat sleep apnea patients in your practice, you're going to have to decide how you're going to deal with medical insurance. You simply cannot ignore it. It is not going to go away. This is a medical condition that we are treating. And that's going to lead you to an answer. You're going to have an answer for a question that you will inevitably be asked every time you present a treatment plan to a patient. Is this covered by my medical insurance? Your patients are going to understand that this is a medical condition. They're going to expect it to be covered by medical insurance, and they're right. This is covered by medical insurance. So you have 2 possible answers that you can give to your patients. It's either yes or yes, but. Any answer with yes and a conjunction like but is going to lower your case acceptance. The best possible answer is yes. And then to explain how you're going to handle it. Because if it's yes, but we don't deal with that, or yes, but you'll have to file and fight with your insurance company, or yes, but we don't know how to do that, all of those things are going to negatively impact your case acceptance. So you have to understand some basic concepts, and in the process, change the way you think, because it will affect how you deal with medical insurance in your practice. And the fact is that dentistry is a medical specialty. It is one of the medical specialties, but it is no different than any of the other medical specialties where a practitioner is licensed to practice in a specific part of the body. We're licensed to practice in this part of the body. This is our hood, the head and neck area. And I know we tend to focus on it, and this will probably come as a little bit of a surprise to you, probably not so much to this group, but the mouth is actually a part of the body. Yes, it is. There's no wall that we've built that when you climb over it, you're in dental land. Things that happen in the mouth have systemic consequences. Things that happen elsewhere in the body manifest themselves in the oral cavity. They're connected, inseparable. But somewhere along the line, this has been misconstrued, and people think that the mouth is actually a separate part of the body. It has nothing to do with the body. It's treated by these weird people called dentists, and it's different, and it's separate. And that's not true, but that has caused our profession to be lost and separated from the medical mainland. And we find ourselves on what I call the island of dentistry. And on the island of dentistry, the first thing that we did was we made up a phony baloney language. Now, in dental school, we all learned the same medical alphabet that our physician colleagues learned. We learned the language of medicine, anatomical references. For instance, blood vessels and nerves are named for the anatomical features that they pass near or through. But that wasn't good enough on the island of dentistry. We invented our own mumbo jumbo. We made up our own phony baloney language, words that mean absolutely nothing to the medical profession. Mesial, distal, occlusal, sinus lift, dental implant, osseous surgeries, those have no meaning at all on the medical mainland. And on the island, we developed a culture of being doers. Consider this. What do we do for a living on the island of dentistry? Let's distill it down to its basic and simplest form. What do we do for a living? We make tooth dust, don't we? Now, some of us will sprinkle in a little bone dust, certainly some acrylic dust if you make a lot of appliances and perform those kind of services, but we have become a culture, a group of dust makers. And a corollary of that is that if we don't do something, we feel like we shouldn't be paid. Now, I practice in Florida, but have you ever had this happen in your practice where you have a patient that presents, let's say, with a benign complaint like an aphthous ulcer? And the patient woke up that morning, they have this angry red lesion in their mouth. It hurts. They've never had one before. They don't know what it is. They call your office. They come to your practice. They sit in your chair. You're paying your overhead, your staff, your water, your lights, whatever, mortgage, rent. They sit in your chair. You use the expertise you gained after 4 years of school and clinical practice since then to make a diagnosis. And it's Mrs. Smith, this is a benign self-limiting lesion called an ulcer. It requires no treatment at this point. You can treat it symptomatically, put some Oragel on it if you like. But if you do absolutely nothing, in 7 to 10 days, it's going to be healed. If it's still there 3 weeks from now, come back and show it to me again, and everything will be fine. Yet on the way out of your operatory, your assistant or hygienist or whoever was assisting you with the patient runs after you and says, Dr. Chris, are we going to charge the patient for this visit? You didn't do anything. Yes, we didn't make any dust. And it gets even worse because on the island of dentistry, disease came to the island of dentistry in the early 60s and completely ravaged it. Do you know what that disease is? Dental insurance. That's right. Dental insurance is a disease, and every disease has a set of signs and symptoms. Do you know what the signs and symptoms of that particular disease are? It's indistinguishable from mad cow disease. Your brain turns to mush. You can't think straight. And you begin to think, oh, thank you for that $1,000 benefit this year. I look forward to next year where I can make some more tooth dust and earn another $1,000. And it's just completely wrong. Medicine doesn't work that way. Consider this. What does our equivalent, the medical GP, do for a living? What do they do all day? Nothing. Absolutely nothing. They think all day. That's what they do. I think you have this disease. I think you need this test. I think I'll make a referral. They think. Physicians are paid to think. Dentists have positioned themselves to be paid to do. I actually had a conversation with my medical GP. I said, Gary, don't tell me how much money you make. That's certainly none of my business. But how much of your fee revenue in your practice comes from diagnostics? Do you know what he said? 85%. But on the island of dentistry, we have to give away the diagnosis or jump over it as fast as we can to get to the teeth where we can make some tooth dust and earn a living. So let me just tell you that medical billing and choosing to treat sleep and medical conditions like this in your practice, you're at a crossroads. And this offers you the opportunity to consider not only the level of care you wish to offer in your practice, but how you wish to be compensated. I don't even like the word dentist. Who came up with that word? Dentist. Of the teeth. We go around telling people we're of the teeth. If you had to come up with a word that describes in totality what you do for a living, especially if you choose to treat sleep patients in your practice, and you can't use tooth or dent or any derivative of that, what would you come up with? Yeah, that's hard, isn't it? I can tell you I thought long and hard about this, and stomatognathes just doesn't roll off of the tip of the tongue, so that doesn't work. Oralist, that sounds a little weird. So I'll tell you what I came up with. And this is the term that I use. I prefer maxillofacialist. Doesn't that more accurately describe the scope of our practice, especially when we're dealing with issues beyond the teeth? And that's important because a maxillofacialist understands a different perspective. And a maxillofacialist understands that just because a dentist performs a procedure does not make it a dental procedure. And that's a key concept. That's an important perception. It's an important shift in perception because we're not just about teeth. And let's go back to that quote. Again, I don't know the clever dentist that came up with that. Clearly, he or she was on the island of dentistry because he says, or she says, that sleep apnea is a medical problem with a dental solution. Dental solution. No, that's not the case. In fact, I would suggest this instead, that sleep apnea is a medical problem with a medical solution provided by a dentist. Very subtle difference, isn't it? But huge difference in perspective. And that will have a huge effect on your practice. My practice became a medical style practice that also treats teeth. And let me tell you, one of the things that I learned is that physicians do not have to argue with patients about money. They don't. Mrs. Smith, you need this CT. Well, doctor, where do I go? Not, I have to pay for it. Patients put a higher perceived value on medical services than dental. That's our fault. I could spend an hour telling you more about that. That's our fault. But the truth is that they put a higher value on medical procedures and services. So the more medical in nature they perceive your practice to be, the higher the value they're going to place on the services you render, including helping them with sleep airway and breathing issues. And the resistance to treatment is going to be less. Now you can also understand why the name of my presentation was Medical Billing in the Healthy Airway Practice, not Medical Billing in the Healthy Airway Dental Practice. So let's be clear about what actually can be billed to medical insurance and how to sort this out, if you will, and to change your perspective a little bit. Let's break it down to its simplest form. You have teeth, that's dental, and you have the other stuff. All of the other stuff is medical in nature. The things that are teeth that have to do with the teeth, that is dental in nature, that should go on a dental claim form with dental codes and be sent to dental insurance for dental benefits. But all of the other stuff, and there is a lot of other stuff, TMD, sinus, bone issues in the maxilla and the mandible that we're discussing, soft tissues, and certainly airway. These are all medical issues that should be claimed on a medical claim form using medical codes. But this will lead you to a concept that will help you divide your practice into the medical portion and the dental portion, because the dental portion needs to go to dental insurance if that's how you roll. Medical needs to go to medical insurance. But it's going to lead you to the concept of medical necessity, because a key thing you have to understand is that medical insurance will never pay your claim unless they are satisfied that what you did was medically necessary. If they believe it is dentally necessary, they're going to politely decline to pay you. That's called a denial. And they're going to suggest maybe you should talk to your dental insurance companies that you deal with. So how do you know what is medically necessary and what is dentally necessary? Well, let's start with this. Dental necessity is very simple. If it benefits only the tooth, the whole tooth and nothing but the tooth, that is dental necessity. Medical necessity, if you want a good working definition for that, use this. Medical necessity is where there are benefits beyond the teeth to the patient, or an underlying etiology is causing you to treat this part of the body. In other words, systemic problems. So let's be a little bit more specific. Chris, what can you bill to medical insurance? What do you bill to medical insurance in your practice? Well, let's be specific. How about this? Exams, consultations that I know you're giving away because that's what we do on the island of dentistry, two-dimensional radiographs that you're already taking, and CT. Trauma to the maxillofacial area, surgical procedures, including frenectomies and frenulectomies, and certainly there are appliances that we are clever enough to construct that go in the mouth that help with larger medical issues like TMD, sleep apnea, or bruxism. And this is not meant to be all-inclusive, because there actually is a lot more than that that dentists provide that can be billed to medical insurance, but we're going to focus on the things today that you would encounter should you choose to help patients with sleep apnea and craniofacial problems that we're talking about. And that would be your exams, consultations, radiographs, CT, lip ties, tongue tie releases, and certainly appliances that help with sleep. But if you're going to do this, this is predicated on making a medical diagnosis. And you're going, whoa, wait a minute. Whoa, I'm a dentist. How can I make a medical diagnosis? Well, the truth is there is no such thing as a dental diagnosis. There are only medical diagnoses. And dentists make medical diagnosis with every decision, diagnostic decision that you make. The truth is that some of the diagnoses we have are all medical in nature, but some will involve teeth and others won't, but they are all medical diagnosis. The problem is, on the island of dentistry, our diagnostic muscle, if you will, has atrophied because we're not used to being asked for a diagnosis to justify treatment. There is no place on the dental claim form that is used today where you have to give a diagnosis code to support the reason for treatment. So we're not used to doing that. We jump over that part to get to make a treatment plan as quick as we can so that we can make some dust and earn a living. But you have to make a medical diagnosis that communicates medical necessity and give that to a medical insurance company for them to consider to pay you. And it's very important that you understand this as well. Doctor, you have to make the diagnosis. That is not something that you can delegate to staff. Legally, ethically, morally, and always possible, it has to be either made by the doctor, and there is one exception to this, and that's if you have a certified medical coder on your staff, which we don't. So doctor, it falls on your shoulders. Now, even though we have atrophied on the island of dentistry in that regard, making a medical diagnosis is not that hard. We all know the diagnosis. What we're poor at is communicating it. So it needs to be a simple thought process. Identify the medical condition. That's the diagnosis. Then you create a treatment plan or care plan on how you're going to deal with that condition. So if you think of it this way, you may jump right ahead to the to the treatment plan, but remember that the diagnosis is the reason you're doing treatment. So let's just get the hang of this, shall we? And I'm going to show you an image, and I want you to make a medical diagnosis. Now, I don't want a code because medical billing is not about codes. It's about making a diagnosis and then finding a code that fits. So I'll show you an image and tell me what you see. I don't need a code. I just want you to think of the words that pop into your mind with this patient's condition. I did warn you have a dry sense of humor, but what do you see? Well, I think there are two possibilities with this, don't you? This is either the worst case of mouth eye that you'll ever see, or this patient has a case of eye teeth. Well, of those two, and let's say that these are both equally right, of those two, which would be the medical diagnosis? Well, it's the one that doesn't involve teeth. You're saying, well, Chris, I was really hoping you were going to give us some codes. I thought medical billing was about codes. Give me some codes, please. Well, I'll give you some codes if you want some codes. Here's some great codes. These are procedure codes commonly billed by medical in nature dental practices that perform these services routinely, and those are medical UCRs, very common for these procedures. And I would ask you, do you do any of these procedures in your practice, or do you want to? Yes, absolutely. So medical insurance is a resource, another method of payment that's available to help your patients make your services more affordable. And I know that we're going to have to talk about this because you're hearing a lot about craniofacial dental sleep medicine, appliances that can help with that. There are mandibular advancement appliances, a whole host of appliances, but the number one most common oral appliance that is billed to medical insurance are mandibular advancement appliances with this code. And you always remember your first claim. You always remember your first of anything, your first car, your first date, your first kiss. And I remember my first claim for a sleep appliance. And this was in January of 2013. Did not really know what I was doing with medical insurance. This was an HMO policy, Blue Cross Blue Shield of Florida, submitted a claim, and in spite of my lack of knowledge, they actually sent me a check. So this is very real, but let's turn our attention to clinical things that you're going to encounter when you choose to go down this path in your journey. And I want to introduce to you Doug. Doug is a patient of mine, and he presented in the dental practice with these complaints. My teeth seem worn, my jaw tends to hurt and pop some of the time, and my wife says I snore. Doc, it's been a while since I've had a checkup. What do you see? What do I need? What's going on? So, what's your diagnosis? Now, Doug is completely healthy from a decay standpoint. Decay and periodontally, he is sound. There's no pocketing, no disease process. There's certainly some recession. You'll notice from the photographs that he has cross-bite. He certainly has a deep bite as well. The color is off a little bit. And if you are early in your journey, as I was when I got out of dental school and just trying to be the best restorative dentist, what would your diagnosis be? Well, you'd say, gosh, Doug, for a man your age, you're actually in pretty good shape. You certainly have a bit of a crossbite. You've had that all your life. I don't think that's a big deal. You have a few crooked teeth, and there's certainly some wear. So what would you plan? Well, again, early in my journey as a restorative dentist, I probably would have just said, you can lighten your teeth with some bleaching if you want. How about some veneers? We might do that if you're not really happy with the color bleaching can offer. And, you are wearing your teeth down a little bit, so we could construct a bite guard. Well, all of that, I guess, is clinically appropriate depending on where you are in your clinical journey. And I would say that that is probably deserving of 1 star. And as you continue your journey through dentistry and you learn more and you recognize more, then you'd say, Doug, the popping, that's not a normal sound. There may be something going on in your joint. So if you just focused on the restorative dentistry, I would say you've earned 1 star. But let's go a little bit deeper and say, why are the teeth worn? It's very important to always ask the question, why? Because the things that you see may be a diagnosis. Worn teeth, that is a diagnosis. But the question is, why are they worn? So if we were to look further, which we did, we would see that certainly he has some things going on in the temporomandibular joint. You'll notice that he has a very, very deep vertical overbite. And notice the lack of space between the temporomandibular joint, the head of the condyle, and the beaking that is present on the condylar head as well. Well, that's not normal. So does he have some sort of TMD? Well, sure. By definition, when you have an abnormal condition in the joint, you have a disorder. So he has temporomandibular disorder. Well, what will you treatment plan for that, doctor? Well, a TM appliance? By the way, anytime you say the word appliance to a patient, do you know what they think? And I've actually asked them. I said, what does the word appliance conjure up in your mind? And they say, well, the first thing I think of with an appliance is a refrigerator or a microwave or something in my kitchen. So appliance isn't really a good word. But if you recognize that you need to offer help with this patient's temporomandibular joint, well, I think now you're up to a 2-star level. By the way, a better word for appliance is orthotic. Think of it this way. Orthotic means that you're going to insert something or alter a body part position to improve its performance or health. For instance, podiatrists, they use inserts all of the time. Orthotic inserts into a shoe to change the postural position of the foot in the patient to improve the patient's health. Well, the same thing would be true about anything that we insert into the mouth used to decompress the joint. Orthotic would actually be the correct term. But what if the temporomandibular symptoms are only just that? They're not the problem, but the symptom of a larger problem. Well, does this patient have an airway issue? Well, based on what you've learned and been exposed to so far, absolutely this is worth investigating. So let's look a little bit further. So we recommended, based on the clinical findings that Doug presented with, to have a home sleep study done to rule in or out whether or not he had an airway issue or if this was simply a temporomandibular disorder. And if you chose to do that, I would say that you've risen to the level of at least a 3-star practice. And as it turns out, Doug's home sleep test demonstrated that he had clinically significant obstructive sleep apnea, AHI of 12.4. That's in the mild range, but that is still considered clinically significant and warranting further investigation and treatment. And in my neck of the woods, if you're wondering what medical insurance will reimburse you for a home sleep test, again, this is pretty average. In our part of the country, we typically bill about $500 or so, and on average, we'll see reimbursements in the $200 to $300 range. And again, your ability to administer a home sleep test, that varies by state. So in states where you can administer a home sleep study, this would be probably typical reimbursement for that type of a procedure. And there are other investigative modalities that you can use to assess the patient's airway. And in fact, some of those things are actually covered and payable by medical insurance to you. But what's your plan going to be now with Doug? Now that you know that he has all of the signs and symptoms of dental issues that are actually pointing you toward a temporomandibular problem that is actually that is actually causing his airway issue. Well, one of the things that you would consider in treatment is, okay, if we have a space problem and the patient has an airway problem, what can we do to improve that? Well, certainly there are medical alternatives as well, but in terms of what we can offer, there's mandibular advancement therapy. That is one thing to consider, isn't it? And the rationale for mandibular advancement is simply to perform some form of rescue breathing for the patient. If you advance the mandible, the tongue will come with it and you'll enlarge the airway. That will manage the disease but not do anything beyond managing it. But if you look closely, Doug's radiographs actually give you more information that would suggest that mandibular advancement might not be the best course of treatment for this particular patient. Notice the degree of vertical overlap. He is closed tremendously, and the effect of that is distalization of the condylar head. He is being forced back by his anterior guidance, if you will, to compress the temporomandibular joint. That explains his symptoms, and he is trapped back there. So you could consider this mandibular advancement, but I wonder what effect that treatment would have on the patient's outcome. Now, would medical insurance pay for this? Absolutely. He has clinically significant obstructive sleep apnea and meets the criteria for medical treatment. And I guess if you chose to do that, then now you've risen to 4-star level of care. And in doing so, you could expect, again, I'll share with you average reimbursements that I see in my area. Again, this is very typical for commercial medical insurance that covers mandibular advancement appliances. And I'll also share with you that even if you choose not to deal with Medicare at all, and have opted out that even Medicare supplements will pay you a small amount toward this type of treatment. But what if we want to go beyond 4-star treatment? And with technology today, we can actually take a comparison. If we have a CT from 2 different dates, we can actually do a side-by-side comparison, which we had available with Doug, and notice the change that has occurred in Doug in 3 years' time. Well, 3 years ago, he didn't have an airway issue. He had almost 3 times the joint space available. He did not have signs and symptoms, but you can see that as his bite has closed down and the increased distalization of the condylar head, now this is where Doug is today. So he has a TM problem and he has an airway issue, which is going to lead us to go beyond mandibular advancement and consider, can craniofacial dental sleep medicine help this patient? And if so, what happens? So again, the rationalization, if you will, what you've learned to this point and what you're going to continue to learn is that tongue space is the critical issue. And in Doug's case, he has a hypoplastic maxilla. There's just not enough space for the tongue. And that available tongue space is going to be causing a problem, causing the tongue move back into the airway. And a lot of reasons for that. Doug did not have extraction and retractive orthodontics. He was simply underdeveloped. But the bottom line is that he has a craniofacial deficiency. And the treatment requires you to consider correcting the craniofacial deficiency. And there are a lot of different ways to do that. Orthognathic surgery is as effective as CPAP for these type patients, but who wants to have their jaws broken? So offering your patients an alternative therapy that addresses the craniofacial underdevelopment present in the patient is the way to go in a patient like Doug. And there are removable appliances that can do this. This is the DNA appliance and the mRNA that is offered by Vivos, but this is a method of treating the underlying craniofacial underdevelopment that has caused Doug to have an airway issue and secondarily a temporomandibular joint issue. And this type of treatment is recognized by the medical community. In fact, on the sleep studies, you'll see that they add verbiage that says that treatment options available for this patient based on their diagnostic finding by the sleep physician include airway enlargement procedures in the cases of maxillofacial skeletal deformity, which means deficiency. So now, at this point in time, now we're able to offer Doug 5-star treatment. And these appliances are billable and payable by medical insurance. But what about other billable stuff that you can bill beyond that is sleep-related that you may not consider in everyday practice as being medically billable? Let's talk about some of those things. First of all, 2-dimensional screening radiographs that you're taking right now, and depending on the technology that you have in your office, the field of view capability of the device that you have in your practice, some of these views you can take independently, others can be pulled out of the DICOM data that you have available to you from your CT. So again, all of these things are available to you, and they each have a medical procedure code that makes them billable to medical insurance. And as you start to learn to evaluate these patients, you'll recognize that these radiographic tools are billable to and payable by medical insurance. This should be very familiar. An orthopanogram that actually has its own medical code and is paid by medical insurance. And what about computed tomography, CT? And one of the things you have to understand from a perception standpoint is if you're going to become a medical style practice that also treats teeth, medical style meaning you're treating medical conditions like airway and temporomandibular joint issues, is if you're going to use CT in your practice, when should it be considered medically necessary? And the question is not really when does medical insurance pay dentists for maxillofacial CT? That's not the question at all. The question is, when does medical insurance pay for maxillofacial CT? Or another way of putting that is, what conditions warrant investigation by CT of the maxillofacial area? And it's not just because the doctor wants one. There has to be a reason to justify advanced imaging that makes it medically necessary and therefore payable by medical insurance. And there certainly is a code for that. 70486 is the code for CT. And the CT machine that I have in my practice also produces all of these views. And if you're wondering what does Chris charge in his practice for these services, that's what is charged by my practice in my geographic area. And what can you expect reimbursement for CT in your practice? This is pretty average. On average for CT, we see about $500 reimbursement for a medically necessary CT, including interpretation. The most I've ever received for CT, if you're wondering that, is about $650. It's going to vary based on insurance coverage, plans, plan type. But again, there's going to be a range, and you'll have to decide what is the appropriate fee in your practice for these services. Well, what about CT for airway assessment? Now, don't get me started on how valuable a tool CT is in assessing a patient's airway. I'm going to talk about how medical insurance views this. And medical insurance currently, and this is changing, but right now currently, medical insurance does not consider CT to be medically necessary for airway assessment, and it certainly is not considered to be diagnostic at this point in time. It's a great tool, valuable tool, highly recommend, love it, but medical insurance doesn't pay for it for that reason. But wait, there's more. Because we know that 75% of sleep-disordered breathing, obstructive sleep apnea patients have at least one sign or symptom of temporomandibular disorder. And CT is a valuable tool in assessing the status of the temporomandibular joint, which is important to do before treating them, isn't it? So medical necessity for CT is based on the following perceptions. There's an abnormal radiographic finding that requires additional diagnostic study, or two-dimensional radiography is inadequate to arrive at a diagnosis. TMD, or making a decision about possible surgery of the temporomandibular joint. That's another reason for advanced imaging study of the joint, CT or MRI. And certainly unexplained head pain or atypical facial pain. All of those will justify billing medical insurance for CT studies. But it's also important to understand that if you're going to do that, you have to properly document the need for the CT in your records. It is not just the doctor wanted it. That is not good enough. And what about the lip and the tongue? Well, your eyes will be open to the effect of the airway on the posture of the tongue, and the posture of the tongue is directly related to its ability to move freely. And when it is inhibited, that is a medical condition that warrants intervention. And the same thing is with lip ties. The attachment of the frenum to the lip, again, medical condition. Let's make a diagnosis. Well, it's very simple. Tongue tie, ankyloglossia is the medical term for that. That actually is the medical medical diagnosis that describes that condition. And of course, it has its own diagnosis code. Lip ties are actually just considered a congenital malformation. In other words, an abnormal muscle development. So I want to address some common medical billing myths before we wrap this up. because I know one of the questions that is inevitably asked of a presentation of this type has to do with the deductible. And the myth is that high deductibles will prevent payment to dentists. Well, actually, a better question is not what is a patient's deductible, but the better question is how will the deductible be applied? And in fact, very few people actually understand what a deductible is. And the federal government defines it for us with 2 sentences. But everyone is fixated on the first sentence, but the second sentence is actually more important, which says the deductible may not apply to all services. And in fact, it doesn't. How do you explain this? This is the same provider, me, same date of service, 2 different patients, 2 different insurance plans with the same insurance company, both have $1,000 out-of-network deductibles. And on the top one, this is for what on the island of dentistry you would call a dental implant. I would never call it that. But that first claim is for a dental implant, $1,000 unmet deductible. And they said, we're going to take $300 now and apply that toward the deductible, but here's your money. And they sent $418.87, even with a $1,000 unmet deductible. The bottom one is for CT and interpreting the CT. And again, $1,000 unmet deductible, none applied to the claim, here's your money. So how is that possible? Well, the way this actually works is medical insurance companies, when they decide they're going to construct a policy they want to sell to the public, the first thing they do is make a list of covered procedures. And if the procedures are not on the list, there is no coverage for that. And of course, good insurance will cover more procedures, bad insurance covers less. But if it's not on the list, there are no benefits. And then the next thing they do in their database when they're creating this policy is they have a column that says, does the deductible apply to this procedure? And they go right down the line. And it is not yes, yes, yes down the line. Is yes, 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 no, no, yes, no, no, yes, no, whatever. That is a policy-specific determination directly related to the quality of the insurance. So, better insurance has more no's. Poor quality insurance applies the deductible to everything, but you cannot assume that a deductible will prevent you from being paid. If you did, you wouldn't expect the payments that are on the screen. So let me bring that concept home and nail it down this way. Let me ask you this. If a tree falls in the forest and no one hears it, did it still make a sound? You're tired? That's a little hard for you. Let me make it a little easier for you. How about this? If a husband speaks and his spouse did not hear him, is he still wrong? Yes, absolutely. So if a policy has a $1,000 deductible and none of it's going to be applied to your $500 claim, does the deductible still matter? No, not at all. Does the deductible get in the way? Certainly. Absolutely, sometimes. All of the times, no, sometimes, yes. So understanding the application of the deductible is what's important. And to illustrate that, these are claims just for exams. I've highlighted the exams on here. All of these were exams for sleep-related patients. Total billed for the exams, $1,200 on the various claims. All of them had unmet deductibles, and the amount paid by medical insurance represents almost half of that. What about best case scenario? Well, as a restorative dentist, I had an opportunity to restore a patient, full arch restoration of a patient's mouth, crowns, buildups, no surgery, no trauma, no airway issue, no nothing. The crowns and buildups were necessary because of a dry mouth. That was the underlying medical condition. This patient actually had a $6,000 deductible, but of the $21,000 billed and the $6,000 unmet deductible. In this case, the policy was written where the deductible did not apply at all, and they paid the full amount. So, you also need to understand with deductibles that even in cases where the deductible is applied to your claim, that still is a big benefit to the patient because you've helped them meet their annual deductible and their out-of-pocket maximum. So you have to understand how to deal with deductibles. And let's circle back to Dr. Pete Dawson's quote earlier, because the material that I presented, you'll need to consider what you're going to do with it when you get back into the office on Monday morning, and certainly that's true of all that's presented to you here today. But I want to circle back to the thing that Dr. Pete Dawson said, that at the time I heard it, it didn't fall on fertile ground. But I want you to, again, consider this. You're going to have to decide if you want to be a tooth mechanic or a physician of the mouth. And there's no right or wrong choice there. If you want to focus on teeth and treat teeth and restore teeth, that's fine. That's great. That's a valuable service. Or you can look at the bigger picture. Look at the patient as a whole. Ask the questions why. Why are your teeth in this condition? Let's look at the entire area within the scope of our practice, which goes beyond the teeth. So again, consider the fact that you have a practice that is filled with patients with undiagnosed sleep-breathing disorders, including obstructive sleep apnea, and these same patients pay monthly premiums to medical insurance companies for benefits payable to you. And you're going to have to decide what you want to do with all of this information. The worst thing that you can do is nothing. You can't unlearn what you're learning in this summit. You can choose to ignore it, or you can choose to apply it. So I want to thank you for your time and attention to my presentation. If you feel like you have benefit in the slides that you've seen today, I'm actually happy to provide that with you. Provide that to you so that you can have a conversation maybe with your team as you consider where you want to go from this point forward on your professional journey. The only thing that I ask is somewhere in the email, if you contact me, please put the word awesome somewhere. Doesn't have to be in proper use. That way I'll know that you were actually a participant of this summit. So again, thank you for your time and attention, and I look forward to seeing you again in the future.